How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're listening to DNA Today, a podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research, we have you covered. For a decade, DNA Today has brought you the voices of leaders in genetics. I'm Keira Dineen. I'm a certified genetic counselor and your host. To learn about a genetic disorder called Duchenne muscular dystrophy, I am joined by genetic counselor Ann Martin, who serves as the VP Community Research and Genetic Services at Parent Project Muscular Dystrophy. Our other guest is going to be familiar to loyal DNA Today listeners. She's returning to the show. She's a world-renowned geneticist, Dr. Madhuri Hegde from PerkinElmer Genomics. She's the Senior Vice President and Chief Scientific Officer of Global Lab Services at PerkinElmer Genomics. She was back on episode 177 of DNA Today, which was a really fun episode where we geeked out on the power of whole genome sequencing. So I definitely recommend you go back and listen to that at some point. And speaking of episode recommendations, we also chatted with Cure Rare Diseases, who the guest on the show, Rich, has a brother that has DMD. That was episode 156. And links to all of these episodes will be in the show notes, which are available at dnatoday.com. And if you're listening in podcast app, usually just swipe right and you can access that. But as I teased earlier, we're going to be exploring Duchenne muscular dystrophy, which we're going to call DMD for short. I'm particularly interested in the genetic testing aspect and the genetics of it and treatment for DMD. But before we get into all of my questions, Ann, I'd love to have you start us off with really just defining what DMD is and what is the average age of onset for symptoms that we see in people that have DMD.
Right. Well, Duchenne, like so many genetic disorders, is really a devastating diagnosis for families to receive. It's characterized by a progressive loss of muscle. So that results in deterioration of the skeletal muscle, but also the heart and the lungs. Boys are typically diagnosed between 3 to 5 years of age, although this still varies considerably even within the United States. They usually present with trouble running, trouble climbing stairs, frequent falls. They often have enlarged calf muscles, and sometimes even language delays, in addition to their gross motor delays. So I would say those are the most common signs. But in terms of progression, boys with Duchenne usually end up needing a wheelchair for mobility around about 12 years of age, sometimes a little later if they're using corticosteroids. But many, unfortunately, die in their teens or 20s from cardiac or respiratory failure.
And as you said, it really is a devastating disorder because right now it's primarily boys that are affected, and that boys are passing away in their late teens, early 20s because of the heart muscles that are affected, because we're looking at this being a muscular disorder, and we have to remember that the heart is made of muscle. When we're looking at this disorder, certainly being in the genetics community, things may be more, we would say something is common versus I think in the general population would be considered rare. So how frequent is DMD in the population? Right.
Well, in the United States, we see about 1 out of every 5,000 boys born are affected with Duchenne. And like you mentioned, I think the X-linked inheritance means that many more boys are going to be affected than girls.
And I think, it's certainly good to know that inheritance pattern is that only females can be a carrier of DMD. So that's certainly something that comes up a lot in my work as being a prenatal genetic counselor. Why is it important for people to be offered carrier screening before they're trying to conceive? Because I'm going to go on my soapbox for a little bit, coming from the prenatal perspective. But why is that important instead of just saying, oh, everybody should just do it during pregnancy?
Well, gosh, I mean, I feel like the earlier you know, the more options you're going to have. So I know as genetic counselors, we always like to say that knowledge is power. So we really encourage families whenever there is a diagnosis of Duchenne to, please talk with their relatives, especially their female relatives, and make sure that they're being offered genetic counseling and genetic testing because, like I said, the earlier you know, the more options you're going to have.
And I think another important part of that is when we're looking at carrier screening, most of the time when someone comes back as a carrier, they probably don't have symptoms themselves. But DMD is an exception to that rule. So what type of symptoms can a carrier of DMD have themselves, even though they don't have the full disorder?
Right. Well, we know that women who are found to be carriers are at risk for cardiac complications. That's by far the most serious complication, and that would be dilated cardiomyopathy. So all female carriers are now recommended to see a cardiologist starting at approximately 18 years of age, and then routine follow-up really based on that baseline exam. Some female carriers can have neuromuscular symptoms such as cramping or muscle pain, weakness. And then, of course, there are the rare females who actually have more classic signs of Duchenne, and they have been called in the past manifesting carriers or the true manifesting carriers. I think we're trying to use newer terminology and call them females with dystrophinopathy, but they're often still called manifesting carriers.
Yeah, I think that's good for people to realize that they should be starting to meet with a cardiologist. And most people, when they get carrier screening, usually they're over 18. So basically, if you end up learning that you're carrier of DMD, you're probably over 18. So it's good to book an appointment with a cardiologist as soon as possible. It seems like at that point. There's no way I'm the only one that's getting sick of Zoom conferences. It's great to be able to talk with people from all over the world, but I have to say the in-person conference, there's nothing quite like it. So I'm really excited to be going to the Connecticut Genetic Counselors Association's first conference in person. Jackson Laboratory is gracious enough that they're going to be hosting us on Friday, October 14th, and they're in Farmington, Connecticut, so that's in the middle of Connecticut. I'm honored to be moderating for the Roe versus Wade panel, where we're going to be discussing the implications for practicing in safe harbor state like Connecticut, New York, other states around us. Other presentation topics include polygenic risk scores, inclusive practice for LGBTQIA+ patients, billing, credentialing. We're packing a lot in. We also built in networking time so that we can meet you, chat, get to know each other. So really looking forward to this. There's a link in the show notes to register. It's $25 if you're going for no CEUs, and then it's $50 if you're going for CEUs. And it's 3 hours worth of CEUs. So pretty decent. Really hope I get to see you there. Support for DNA Today comes from the People for the Ethical Treatment of Animals, also known as PETA, whose scientists have developed the Research Modernization Deal, a strategy to phase out ineffective experiments on animals with high-tech, state-of-the-art research. PETA has collected an abundance of evidence demonstrating that the use of animals in biomedical research hinders scientific progress and puts patients at risk. Learn more at peta.org/New Deal. Again, that's peta.org/New Deal. TrackGene has designed a genetics electronic health record. Here's what it features: pedigrees, demographic data, genetics information, risk tools, and sophisticated reporting, all within a clinician-designed workflow. It integrates with other clinical genetic software, databases, and hospital information systems to maintain accurate patient records. Go check it out at trakgene.com. Again, that's TrackGene without the C.com. And keep your eye out for our full episode interviews with TrackGene coming soon to DNA Today. I mean, with the increasing adoption of expanded carrier screening and prenatal genetic screening and testing with amniocentesis and CVS, Are we starting to see a shift where people are diagnosed earlier? As we said, most people that have it are boys, and usually symptoms would have their onset at like 3 to 5 years old. But with all of this carrier screening and prenatal screening, are people more often diagnosed when they're asymptomatic before symptoms even start?
Yeah, I mean, we have definitely seen a huge increase at PPMD in terms of the number of women reaching out who have no family history of Duchenne or Becker, but then they're diagnosed as a carrier through the expanded carrier screen that's being offered at most OBGYN offices now. So this can certainly be a really challenging situation, as you know, as a prenatal counselor yourself. So, it's especially challenging when we're identifying some in-frame deletions and duplications that maybe have not been reported before in the literature. That makes the genetic counseling really difficult. And we've actually worked with several families now where we've done familial testing and found that there are adult males in the family who carry that in-frame variant but are apparently asymptomatic. So,
which is surprising.
Very surprising. It's definitely been very eye-opening, and learning that the more we know, the more we don't know. So
yes, that's the theme of this show, I think.
Yes, for sure.
And so as Anne's bringing up, the genetics of DMD, this is, interesting. And I'm also thinking about, as we were talking about like carrier screening, like more people are finding out at that point. Dr. Hegde, when we had you on back on episode 177, we talked a little bit about newborn screening and how PerkinElmer is really a leader in this field. Do we see DMD on newborn screening, or is this too hard because onset's later? Like, how does that work?
So not yet.
Not yet. I like that answer.
Significant effort from many advocacy groups, really led by PPMD, and a lot of physicians, and sort of a lot of activity around that to get DMD included in the RUSP panel. Unfortunately, it is not that easy either. One of the criteria for newborn screening is that there has to be an effective intervention. And that's been challenging, right? I mean, if you look at the list of disorders that are included in the RUSP panel, I mean, you've got cystic fibrosis there, and it has always been there. But Duchenne is right now not on RUSP, and there is significant activity going on around that. But having said that, what PerkinElmer did a couple of years ago was take a little bit of a proactive step in getting into the direction of newborn screening. So PerkinElmer has a CK-MM assay approved, FDA approved for newborns. So that assay could be easily sort of put into any laboratory which is doing the state labs which are doing newborn screening. It just goes on the same instrument which is used for the FDA approved other assays. So in terms of readiness for newborn screening as an assay, is there an assay available? Yes. So, but CK-MM is not the primary biomarker for Duchenne. That's something to be remembered. I mean, there is so much debate around several things for Duchenne, right? It's not the primary biomarker. The second thing is that the affected gender is males, and Anne and I have been on several meetings and committees where this discussion comes up. Should the testing be limited to gender, to males only? But newborn, that is not the principle of newborn screening. All babies.
That would be a whole nother level to it. Like we don't stratify in that way.
No, but also manifesting carriers are known, so there's no reason to limit it. And then follow-up testing is very important. So if CK is high, then it needs to be sort of go to tier 2, which is a molecular confirmatory testing. And fortunately, in the molecular world, things have evolved significantly, like what we talked about on our episode of whole genome sequencing, that we have come such a long way. I mean, I remember my PhD, most of my PhD was on DMD. And, we were doing the 32-plex PCR for 32 exons to look for deletions, and duplications had to be done by a certain lot. And we have come from that today to you can look at deletions, duplications, and point mutations in one single assay. So things have, and I remember talking about the cost of the assay at one point, and things have come a long way since then also, that the cost of the assay itself has also reduced significantly. So in terms of the testing, I think we are there, right? CKMM as a FDA approved assay to be done for newborn screening, and then follow-up testing for molecular to identify the precise molecular event. And that is a very important step, because now many startup pharma companies are jumping into rare diseases. And fortunately, there's a huge interest in DMD. There are different strategies that are being designed right now to address different types of mutations. And there's a whole list of pharma companies right now which are interested in Duchenne, largely due to the efforts of PPMD. So we are getting closer to that point, but I think the next step really is that early diagnosis step, right? Where we either get it in newborn screening or make sure that in the pediatric evaluation, the baby well check visits, that it's included, that this is an important disorder to be included in that early check sort of process, especially in the first 2 years or the first 3 years when the baby goes to the pediatrician.
Yeah, that makes sense. So in terms of workflow, more population-based screening for infants with the biomarkers you were talking about, and then if something comes up with that biomarker screening, then dive into the molecular genetics. Am I getting that right?
Yes.
Because, I mean, DMD is the largest known human gene, which I think was one of, like, the quiz questions at, like, NSGC for one of the companies. Maybe it was one of you guys, I would think. But there's 79 exons and 2,300 kilobases. So it's massive. This is a huge, huge gene. So it makes sense that the genetic testing is really complicated. And as Dr. Hegde was saying, like, you did your thesis on this, like, you're doing, back for PhD, like, having to do multiple different types of assays to be looking at to get information on one gene. Yeah. So, it's really interesting. So if we were talking about it from like a population screening standpoint. Let's hone in a little bit more on if we're suspicious that a child has DMD, either because we found out that the egg donor or the biological mother is a carrier of DMD, where we're like, okay, now we know there's a 50% chance, or for some reason, there's some other suspicion. Maybe their male cousin has DMD, something like that. What is the first genetic test they should order at that point when we're talking about a certain person that we're suspicious for?
I mean, I still think initially I guess it really depends on the setting, but typically the first test ordered is the CK test, because it's such a quick and simple test and inexpensive. And the CK is always dramatically elevated in boys with Duchenne and even Becker. In some cases where there's a known family history, I think obviously, and especially if the genetic variant is known, we could do familial mutation testing just to look for that specific variant. But I'd say most of the time we're ordering the next gen sequencing panel, through PerkinElmer, which, really identifies, as Madhuri said, all of the deletions, duplications, and the smaller copy number variants. So that is really the best test to order.
Yeah, because we were talking about, go ahead, Dr. Hegde.
No, I was just going to add to that is, again, like science has come a long way, and today we can also do the testing on multiple sample types, right? So dried blood spot cards, saliva, or a whole blood sample. Many pediatric cases at times it's difficult to collect whole blood. So, there are different options available now to do the test. And what I mean is you can do on the same blood spot, the CK assay, and that same spot can be used for the molecular testing. And the reason I mention this is that you do not want to lose a child to follow up, right? You want to make sure that the testing gets completed. And by that I mean that if the CK is high, the next step of molecular confirmation occurs. And I think Anne and I have been through many situations where, over the past 20 years, sometimes you see this, it depends on where the test is getting done, right? People live in different geographical zones, and maybe, the access to testing is just limited to doing deletions and duplications only. So if that is negative, you want to make sure that the testing is completed to look at the point mutations as well. What we have at PerkinElmer is just one single assay, and that was really my intention, that I did not, having gone through this exercise of, loss to follow up, the physician doesn't know what to do next. Having that one single assay which catches everything was very important. But the options are many now, and I think this is really important to remember, that making sure that the testing gets completed if CK is high is very important.
I think also important is to point out that we've really worked hard to reduce any barriers to genetic testing. That was the whole point of PPMD. We launched the Decode Duchenne genetic testing program, which is a free testing program that we actually run with PerkinElmer Genomics. But we started the program back in 2013, and it's really been a phenomenal program, and just a great example of how, it's industry sponsored, but it's industry working with an advocacy organization and working with a laboratory to truly benefit the community, because we've been able to provide free testing to, over 2,000 individuals at this point. And
Wow.
we do not only diagnostic testing, but also free carrier testing, which has been huge for women.
That is huge, because some of these programs that I hear about, which it's such a beautiful combination of like nonprofits and then industry working together to get people this, no cost genetic testing. But usually, some of my follow-up questions are like, oh, well, do you offer carrier screening then? They're like, oh, we don't offer that part. So it's really cool you guys are extending that part of it as well, because a lot of people are looking at future pregnancies, or their siblings are, like other people in the family that are certainly having a chance to also be a carrier or be affected. So it's really cool to hear. And I didn't realize, to be honest, how long Decode Duchenne has been going on. So you guys are going on 10 years next year.
I know, big anniversary coming up.
Yeah, definitely. I feel like we should have recorded this next year, except I want to get this message out to people, right?
Right.
And I think something else I want to pull out of what we've been talking about is, once you get to the point where you're doing genetic testing, if the biomarker levels are high, it's important to make sure you're ordering the right genetic testing. So Dr. Hegde, why is it important to include the deletion, duplication analysis? Like, there's all these different aspects of the genetic testing. It's not just, sequence it, we don't see any variants or mutations. It's more than that.
So the DMD gene is a unique gene in the human genome, not just by size, but also the types of mutations you see. So most of the genes, what we see, about 80% of the events are point mutations, and about 20% are deletion duplication. DMD is unique, right, in that sense that you're now flipping that, where deletions and duplications are about 60% deletions, 5% duplications, and 35% point mutations. So traditionally, the approach was, because deletions and duplications could not be detected when you are doing sequencing, the traditional approach was to do a multiplex PCR, run it on a gel, and if the exons don't amplify or you don't see a band, you got a deletion there, right? Duplication was a little harder, and that's why Southern blotting was done. And then if that is negative, then you go and do Sanger sequencing.
So now you're on step 3.
Exactly.
Like, wow.
Yes. Yeah.
All for analyzing one gene.
Correct.
That's a lot.
And in that process, we have been through many cases now where sample comes and you see that, this was done and that was done, and even in deletion duplication it was complicated. Not all 79 exons. It started with 16, then 32, and so it has been an evolution of processes. But with next generation sequencing becoming available, now you can detect deletions and duplications with point mutations in one single assay. I think the next step of what we took at PerkinElmer was, and just given my own interest in neuromuscular disorders and Duchenne specifically, was given the size of the gene, right? You got a 2.3 megabase gene you're looking at. What I decided to do was to develop an assay which sequences the entire genomic sequence of the DMD gene. So we are talking of literally a DMD genome, if we can say that.
I think we can because of how big it is. Yes.
Exactly.
I'll allow it.
And the idea really was twofold. About 2% of the mutations are in the introns, deep intronic. And those cannot be detected if you're just sequencing the exons and the flanking boundaries. And then I think from my perspective and my team's perspective at PerkinElmer, you know, being that sort of leader in newborn screening and making sure that not just identifying the child, but sort of taking that next step is to getting answers, right? What can be done next? And we have all heard about CRISPR-Cas9. But for CRISPR-Cas9, the main important thing is they need to know where to put that RNA guide. That means they need to know, so if it is a deletion, they need to know what is the breakpoint of the deletion. And those breakpoints are in the introns. So now if you're not sequencing, so now you're introducing step 4 probably, that after testing, if the child is eligible for, let's say, exon 51 CRISPR-Cas9 approach, now you need to know where the breakpoints are and you need to do another round of sequencing. So this one single assay now is helping you capture everything, all types of mutations down to the deep intronic mutations, but also knowing where the precise breakpoint is, and that information then we can give to the pharma company which is developing the assay to know where to actually design the therapeutic target to. So again, we have come a long way in technology, and fortunately we are at a place where we can actually facilitate this.
Yeah, and I think with CRISPR, there's so much potential there, and DMD would certainly be a candidate for that, as long as we give, like, I think about it like CRISPR is like a car, and we need to give it a GPS coordinates to say, you're going exactly to this spot on the gene, because DMD is like a huge continent. It's just like, all right, you got to give a specific address so it can get there and know exactly what to fix. So that's really interesting that, you know, you just have this one assay, one test that can cover all of these angles that we've been talking about. And as you said, I mean, the point of doing the testing is not only to have an answer and a diagnosis, but to say, okay, now how do we treat this person?
Yep.
And, you know, I have to say, one medication that I've been following is Spinraza. I mean, this has been a game changer for people with spinal muscular atrophy. And, you know, this is groundbreaking. I mean, I was in grad school when this, you know, was coming out, so a few years ago. And, I mean, I'm still amazed by it. I think this is really a landmark in terms of gene therapy and looking at treatments. It's for a muscular condition. So is there any current treatments and approaches that are using information from Spinraza? I'm just thinking, like, they're both muscular conditions. Is there anything in common that we can use, or is it just too different?
Well, I mean, I could say, you know, there's certainly a lot of interest and excitement around gene therapy in Duchenne right now. We have several actively recruiting clinical trials. And they're showing a lot of promise. So, of course, they're still in trials, so, you know, nothing has been FDA approved yet. But there's definitely, you know, a lot of excitement focused around gene therapy, but also a lot of hurdles. I mean, we know there are immune response issues. There's the whole question of the, you know, duration of the effect, and whether or not we could ever redose these boys who do receive the gene therapy. So there's a lot of hurdles we have to work through with gene therapy, but I think it's definitely an exciting time in Duchenne. You know, we're fortunate in the Duchenne space, if we can say that, but I feel like we're fortunate in that we have so many researchers and so many industries who are interested in Duchenne and focused on Duchenne, and they're all targeting it from a different angle. I mean, so there's those who are looking to restore or replace dystrophin, but then there's a lot of companies who are looking at other effects, like how can we target inflammation or fibrosis or improve muscle growth or, restore the cell's energy. And so I think tackling it from all these different angles is so important, because in the end, I think we all believe there's not going to be one magic cure for Duchenne. It's going to be more of a combination approach.
Yep. And I'll just add to that. I think, one thing is about basically understanding the differences in the genetics of both disorders. And both disorders have their own unique situations. So DMD, a large gene, multiple mutation events. Each event, a deletion approach is going to be different from a duplication approach to a point mutation approach. Now you flip that over to SMA, and you have two unique situations here. There's only one real mutation event, which is exon 7 homozygous deletion.
That makes it way simpler, and everybody could have the same treatment then. Yeah,
So
that's a good point.
Yeah, so 95% of the kids are going to have the same event. 5% do have a point mutation, so you need to sequence the gene. But then the other thing which has sort of worked for SMA is the SMN2 gene, the pseudogene event. There's only one single nucleotide which differentiates SMN1 from SMN2 in exon 7, which is the advantage that has been sort of afforded to develop the therapeutics for SMA, right? But the approach is different here, because you got one event, you got this pseudogene, you got SMN2, and people have, now we report not just SMN1 copy number, but we also report SMN2 copy number, because that is an important note that pharmaceutical companies need for the therapeutic strategy. So I think there are different disorders, but there's a lot of learning from it, that how to, it's not about just developing a therapeutic approach, but what comes with, it's a full programmatic approach, right? The way newborn screening is a program, it's not a test. It's the same thing. What comes with sort of identifying and then making sure the treatment is given, and then what Anne just mentioned, all the other effects have to be assessed. Is there inflammation, and what else could be going on? And the functional genomics part of it becomes very important. To how are you going to look for gene expression, and what is the functional aspect of it? Seeing gene expression doesn't mean a functional effect that the boy is actually walking. So there are so many different events that need to be tracked post sort of developing a therapeutic approach.
This is a shocking statistic. The National Institutes of Health, or NIH, the world's largest funder of biomedical research, squanders an estimated $200 billion of taxpayer money every year on ineffective animal experiments for human diseases. The NIH reports that failure rates for novel drugs occur in about 95% of human studies, despite showing success in preclinical experiments using animals. Animals and humans deserve better, which is why scientists for the People for the Ethical Treatment of Animals, aka PETA, have developed new strategies for replacing the use of animals in experiments with human-relevant methods. Advances in human-relevant research technologies hold tremendous promise to revolutionize biomedical research and usher in the age of personalized medicine, a topic we explore extensively on DNA Today. Head over to peta.org/New Deal to learn more. Again, that's peta.org/New Deal. Have you heard of TrackGene? TrackGene is a clinical genetic software solution used by over 1,000 genetic experts around the world. You can customize the front page so it's streamlined to your specific workflow. The intuitive patient information entry page makes data entry efficient and user-friendly. Pedigrees are also easy to draw and document. Here's another vital feature. It supports HL7 integration to be used with other clinical genetic software, databases, and hospital information systems. So you can build custom reports with the simple drag and drop report builder. This has an interface with data visualization tools such as those from Microsoft to make it easy workflow. And there's more features on the way, all designed with you in mind as the genetics expert. TrackGene has an experienced team who's been working in the clinical genetic industry for, get this, over 15 years. You can request a demo for free. Go to trackgene.com. Again, that's TRAK gene, so track without the C.com. Stay tuned for upcoming episodes of DNA Today, where we're going to be chatting with TrackGene. And for people to keep up with this, I think is very challenging. It's challenging for me as a provider. But luckily, PPMD has a great resource, parentprojectmd.org. And can you tell us a little bit about, as we wrap up, the guides that you provide, especially for caregivers of newly diagnosed kids?
Yeah, well, like you said, we do have a great website. I mean, we have a ton of just wonderful information on our website.
There's so much on there. Like
There's so much. But
which is amazing.
Yeah, it's amazing, but it can also be overwhelming, especially for the newly diagnosed families. So we actually have a newly diagnosed section. It's under the About Duchenne tab of our website. So hopefully the newly diagnosed families find that. I think it's really nice. It actually starts with a note from Pat Furlong, who is the founder of PPMD many, many years ago. She's still our leader. She actually had 2 sons with Duchenne. So I think the note is just very personal, very touching. But the other thing we really try to focus on in the newly diagnosed section is to take it slow, that this is really overwhelming. And I think the most important thing to do initially is just adjust to your child's diagnosis, but also work to get them into a neuromuscular care center that's really focused on Duchenne. Like, we have several PPMD certified Duchenne care centers, so we always encourage families to try to get to one of those centers. I think that's the most important thing to do initially, and then as you settle more into the diagnosis, then you can tackle learning more about all of the research opportunities, or possibly connecting with other families, or getting involved in PPMD events. The options are endless, but I think it's most important for families to really just take it at their own pace and do what feels best for them. And then we just always want to make sure people know that we have a great staff here at PPMD, and we're always available to help families every step away along that journey.
Well, I think that's beautifully said, and it's just such a great home base for people to go to, especially the parents and caregivers, to learn more and also have that sense of community. I think that's really important from, interviewing patient advocates over the years on this show. But thank you so much. I'm shocked the episode's already over, because I think we could all talk about this for so long. But thank you, Dr. Hegde. Thank you, Anne, for coming on and just sharing all of this experience with us. And we're definitely going to link to everything we talked about in the show notes. That's all available at dnatoday.com. So you don't have to remember everything. You can just go there and find the episode. So thanks, everybody, for listening. And thank you, Anne and Dr. Hegde, for coming on.
Thank you for having us.
Thank you.
Bye.
Thank you.
For more information about today's episode, visit dnapodcast.com, where you can also stream all episodes of the show. We encourage your questions, comments, guest pitches, and ideas. Send them all into info@dnapodcast.com. Search DNA Today on Twitter, Instagram, YouTube, Facebook, so you can connect with us there. And a favor, please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. DNA Today is hosted and produced by myself, Keir Deneen. Our social media lead is Corinne Merlino. Our video lead is Amanda Andrioli. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA.